So I wanted to welcome everyone to this seminar series. We have the great pleasure of hosting Dr. Jeff Weitzel, who is the Vice President of Medical Affairs, Hereditary Cancer at Natera, and the professor in the Latin American School of Oncology. I'm going to be brief because there are a lot of accolades that I could talk about regarding Jeff. So he's board certified in medical oncology and clinical genetics, which for many of you who may not realize this, there are very, very few in the country that are dual board certified in these two specialties. He's been pioneering the implementation of genetics and genomics in clinical care, addressing disparities in access and harnessing technical advances to conduct innovative translational research, spanning the bench, the bedside, rare diseases, and diverse population. He built world-class programs in clinical cancer genomics and related education and research over 2 decades when he was at the City of Hope, including intensive training of over 1,300 healthcare providers in the implementation of hereditary cancer testing in multidisciplinary settings spanning all 50 states and 27 countries. And some of this he will talk about with his talk today about implementation of clinical cancer genetics across Latin America. He's the founder of the Cancer Genomics Community Research Network, which is a prospective registry, has over 30,000 patients. Again, the reach of this training program to many of us who are in the field is tremendous. He's had many awards and accolades, including being merited the 2019 American Society of Human Genetics Arno Motulsky Barton Childs Award for Human Genetics Education. He's also a Breast Cancer Research Foundation Scholar and an honorary professor of oncology for the Latin American School of Oncology. He was awarded the Conquer Cancer Research Professorship in Breast Cancer Disparities at the ASCO 2020 meeting. So like I already said, that I was trying to keep it brief, but Dr. Weitzel's got a lot of accolades, so we're really looking forward to his talk focused on his work in Latin America.
Thank you for the very gracious introduction to you. I want to make sure everybody can hear me okay, so everything's clear. Perfect. Well, it's a great honor to be presenting for Vanderbilt. I have many dear friends there, and already shout out to Georgia. So we've been corresponding in the chat box a little bit, but really this is a labor of love that I want to talk about, and truly translational. And the other thing is that it's going to be a talk about really learning what I thought of as pragmatic science, which is what implementation science is. You know, it seems typical. We have to get advances and then get them to be employed in the field. And they've now made a science out of it. So that might sound naive, but I am naive in the context of implementation science, but I really believe that applying it is critical. So let me share my screen and go from there, make sure that everything is working the way it should, and I believe it is. Perfect. All right, good. So again, a great pleasure to be invited. And so today I'm going to focus on the topic at hand. And I know this is a precision medicine series, and I will cater to that a bit near the end of my talk in the sense of precision medicine, but really genetics and genomics in the care of individuals. We were the first personalized medicine. I mean, what could be more personalized than genetic predisposition and understanding an individual's risk? So really the precursor to all that we think about in terms of precision medicine is the precision of genetics and genomics. Oops, that's fine. All right, so my disclosures, do Speakers Bureau on DNA repair for AstraZeneca, and I'm a relatively new employee of Natera. Now, we start with the sort of broad question of, you know, how much breast and ovarian cancer is hereditary? And then the question is it different in different populations? And moving from, we know that at least 10%, 5 to 10% of breast cancer may have a hereditary basis, and ovarian cancer is very genetic, and it's not 15%, it's closer to 25%, and we'll cover some of that data. But it's clear that we have both moderate and high-risk genes, and that they're all involved. But the question is are the patterns different? Are the proportions different in different countries? Now, if one wonders, because of a lack of genetic testing, largely in Hispanic populations, whether there's hereditary breast cancer there or not, I don't know how many of you still know Soraya, but she was a wonderful songstress, just wonderful. She won a Latin Grammy. And this pedigree that you see to the right is actually, it's not, personally identifiable health information that was privileged. This was actually from her obituary, unfortunately. And so here's a woman who was diagnosed with breast cancer at the age of 37, whose mother, aunt, and grandmother had breast cancer. Okay, so the real tragedy here is that she wasn't forewarned about the potential for genetic risk, because clearly this is a hereditary pattern that we all would recognize. And access to care influences knowledge of genetic epidemiology. And I'm thinking about, your own Dr. Powell, Tuya has done lots of wonderful talks about disparities in access to care. And this will be complementary to that, a flavor of the same. So when I think about my friends, the little circle there is on Nigeria, but I'm thinking of Fumi Olopati and Tim Repik and others who've done work in Africa. But really, 90% of what we've known about genetics of cancer have come from United States, Europe, Iceland, and Israel because of founder populations. Australia's got a very well-developed cancer genetics system. And there's a lot of new data coming out of Malaysia and other places in the Far East where we're getting more. My focus has been going straight down south, keeping the time zones closer rather than transcontinental, but really Latin America. Why? In part, because of the demographics of where we live. Now, I live right here on the left, at the left coast, we'll call it that. It's actually very blue, not red, but we've got Los Angeles right here. And look at how red that is with regard to foreign-born from Mexico and the United States. This is in 2000. The pattern the red has only gotten a little bigger in most places. I think one of the places notable, so the whole Southwest obviously has a large population of Mexican individuals who are transplanted, a lot in the South. So think Florida, and that's mixed them with Caribbean Islanders. And even in Chicago, one of the largest, fastest growing populations is Hispanics. Yet they've been disproportionately not tested with regard to genetics. So some of the work I started doing early on had to do with addressing those populations. So what was the first thing we did? One of my dear friends, Nancy Feldman, was at the county hospital in Los Angeles. This is San Fernando Valley, Olive View Medical Center. Now, she came to me in about 2000 at a breast cancer retreat that we were all together at, sponsored by USC, and said, Jeff, we're dying out here. We have 32-year-olds with stage 3 breast cancer, and yet they're not getting access to genetic testing because at that time, Medicaid wasn't paying for BRCA testing even. And so what do? We do what people with a conscience and a mission do. I started a pro bono clinic at Olive View, and I hired bilingual, bicultural counselors and research associates. And ironically, I speak French, not Spanish. You'd think with all the work I've done in Latin America, I would have cracked open my Rosetta Stone that I bought but never opened. But nonetheless, we started out by making science of it. So it's, of course, service, but science. So we did a survey and about beliefs and interest in cancer risk counseling in these underserved cohorts at several centers. That Queen's Care Health and Faith Partnership was another one that was a community-based organization. At Olive View, about 89% of the service population is Latino, and many of them first-generation immigrants. Now, what we found from this was that when given a chance on an anonymous survey to indicate their contact information to learn more about prevention, that despite issues of trying to find housing, issues of trying to survive in this country, they were very interested in prevention. We also got a little bit of knowledge about that they understood that genetics could have an influence. So we figured there was readiness. Then if you build it, will they come? And of course, those of you who knew the movie reference there, the idea was if we build a clinic, will they come? And I will tell you that they attended my clinic better at the county hospital than they did at the City Pope main campus, honestly. One day when there was a bus strike, they walked 5 miles to come to our clinic. And a lot had to do with some of the coherency we had with regard to, I'll call it, I think the current verbiage is cultural humility. And that is knowing how to identify with them to have good communications. Charité Ricker, who's been a leader in this area, she continues to be just a champion at LA County USC, and really takes care of that population in the most wonderful way. And she's written many of the papers with me about this work. And this was a lot of my team at City Hall. But nonetheless, point is, yes, they will come if you build it. And what is cultural humility and first acronym, Genetic Cancer Risk Assessment, GCRA, it'll be used recurrently. So some of those principles are familialism, so the significance of family to the individual; collectivism, the importance of friends and extended family; fatalism, we talk about, one of my colleagues from New York used to call it destino, because fatalism believes you have no power to it, but destiny means we have a pragmatic understanding that this may be our destiny. So they would argue that it's destino, not fatalism, that is more of a religious construct. And then trusted messenger, and this is one I identify the most. Must be familiar with the culture, be trusted, and the culture group must identify with him, her. And some of these, being the trusted messenger, can be a physician, somebody who cares about their family, so the significance of family to the individual, and is willing to be out there for them. So we become a trusted messenger. And these are really principles from Huerta and others, dating back quite some time. We also worked together to do some studies of the social cognitive aspects of underserved Latinas preparing to undergo cancer risk counseling, and really felt that they had many of the skills that were necessary to prepare them to learn about genetics. And along the way, by delivering this care, we backed into, I like to say, the genetic epidemiology of BRCA in the Latino population. So this first paper, Prevalence of BRCA Mutations and Founder Effect in High-Risk Hispanic Families, was published in CEBP in 2005. It was 131 families, 28% of them had a mutation. Now, they fit high-risk profile. They were all affected, many of them young. I mean, you have to think about the gauntlet that happens when only the worst case is being referred, but nonetheless, it showed that it was clearly prevalent. Second, we made some observations in that cohort that there were recurrent mutations, which I will come back to in a moment, that related to ancestry and anthropology. And then second, in 2007, we were able to publish on a large genomic rearrangement that I discovered. And how did I do that? I approached Myriad Genetics when they first came out with their BART test and said, all right, I did this people testing in your lab. You've long since discarded those samples, but I have this cohort of people who are BRCA negative according to sequencing, and you should apply your BART to them. And as long as we don't patent it, I'll go along with you. They tried to, but they didn't succeed. And I'll explain in a moment why. But nonetheless, we discovered on the very first gel of the BRCA negative families that there were 3 families that shared the same large genomic rearrangement, which is the deletion of exons 9 through 12. And I further sequenced into the introns, turns out they didn't own the introns, and found the breakpoints, and then designed a 3-primer assay. Primer here, way out here, a primer here, and these 2 are intronic, and they'll always give a band because that's the normal at the top. The smaller band, where you might expect PCR artifact, turns out to be, if this deletion happens, P1 connects with P3, and you get the second band. So it really, if there's PCR bias, it's going to favor identifying the mutant band. And in all cases, you should see the wild type, since you don't see homozygous individuals. So homozygous normal, and all these are heterozygotes. So it turns out that I can do this assay on the bench on a 2% agarose gel in 2 hours for 98 cents. So we use this to screen virtually everybody thereafter, because it turns out to be a very important frequent mutation, and I'll talk more about that. Also, Veronica Lagos was one of my research associates who did her molecular pathology master's program at USC, which is why I was collaborating with Mike Press and others from USC. And she studied the characteristics of BRCA-associated breast cancer. We saw some subtle variation in terms of the prevalence of progesterone receptor in these individuals, but nothing else signature. It looked like BRCA1 or BRCA2, which was what they had. We also went along, and I had created a registry, which again, I'll talk a little bit more about, and that I think Dr. Powell has done a marvelous job creating her own registry pattern in many ways after what we had done. And what I'll point out here is that this was, at the time, it doesn't sound like a lot of participants, but 746 people at the time we published this in 2013 was a significant number of Latinos. And in fact, around 2009, when Myriad first published their data on sort of ethnic subgroups and the prevalence of mutations, they had about 1,800 Hispanics total. And I think at that time I was responsible individually because of our outreach clinic for 500 of those 1,800. So significant measure. Now, these were also high-risk families, so 25% of individuals had a BRCA variant, 189 out of 746. Notably, a lot of large deletions, and they were beyond the one that I found, but the one that we found was at least half of them. So 11% of the individuals had the large deletion that I found and discovered was a recurrent founder mutation from Mexico, and others were also observed. So we know that large genomic rearrangements are important, and Myriad ultimately found data that corroborated that and showed the importance of this specific variant because although they mixed Caribbean and Pacific Islanders. Now, this is sort of a schematic that summarizes our paper, paper from Texas, and Esther John looking at the Cooperative Family Registry's breast cancer, and then another paper we did with Dr. Cynthia Real Garza, who was at the INCAN, the National Cancer Institute in Mexico City. Well, what do you see here? This is your BRCA1. Here's BRCA1 looking at it, different populations, different studies, each bar. And the large genomic arrangement is featured here. You see, we saw 13 of them in our studies to date at that point. But here's the other one we saw, 185 del-Ag. I know it's the old nomenclature. You all should know that as the Ashkenazi, what is thought to be Ashkenazi Jewish founder mutation, but it's Jewish to be sure, but it's not Ashkenazi. It preceded the separation of the tribes and the Ashkenazi in Eastern Europe. So this is also seen in Sephardic populations. And in our 2005 paper, we actually did the haplotyping of my West LA Jewish population against the ones I was finding that were multi-generational Catholics in the Hispanic population, and they shared the same haplotype. So we demonstrated this common origin, and I'll talk more about that in a moment. R71G here is also stacked up pretty high. That's a Spanish founder mutation, was first reported in Spain. And even though it is a missense mutation that is predicted to be pathogenic by all of the protein models, it turns out that it, like many SNVs, it actually introduces aberrant splice at the penultimate base in that exon and causes a truncating mutation because of that. Intervening sequence 5 plus 1G to A, another one that was recurrent. Now this one right here, 943 insertion 10 is interesting. So what makes up mestizo? Well, you've got indigenous American, or Amerindian as they were once called. You've got European influences, primarily Spanish, and then you've also got African because of the diaspora related to the slave trade. And so 943 insertion 10 turns out to be an African founder mutation. And so fascinating to me, we're seeing all of these variants that are there and are relevant. A1708E is also a founder mutation from Spain. So you see a mixture of their ancestries being reflected here. Now, what's impressive about the one at the bottom, or the red bar here, is that this is Dr. Villarreal's study in Mexico City. They found 13 exon 9 to 12 deletion cases out of a much smaller N than I had in the top bar. So even though it's the same number, N is 13, it's a much larger proportion when you're sampling specifically from central Mexico. Now, a little bit about history. I loved going to the Prado in Madrid, and I couldn't help but take a picture of this. This is a picture of Quasimodo throwing down a crucifix in front of a Jewish shopkeeper who was trying to befriend Ferdinand and Isabella to prevent them from persecuting the Jews by giving money to support the war effort. But of course, history ultimately meant the Spanish Inquisition. So we all know, many of us should know about the Jewish diaspora that related. They either were forced to convert to Catholicism, were killed, or had to move. And at one point, so many had moved to Portugal that being Portuguese was synonymous with being Jewish. And of course, many then moved on to the New World. And that's where the trail kind of got lost a little bit in the sense of how complete was this diaspora? How intermixed did they become in that respective population? And I'll make the case that I believe that they became well integrated and apportioned. Of course, on the right here, this is Galileo in front of his inquisitors. And, you know, one of my favorite lines, and I doubt that it's really true, but they said that his retort to the inquisitors was, "She's still around." So in any event, I learned a lot about anthropology through my studies here. Now, what about ethnicity? So we can do ethnicity with SNPs. This is ancestry informative markers, a K of 3, which divides it into just 3 subsets. But what I wanted to highlight here was I got samples from the cooperative family registries from New York, which were predominantly Puerto Rican and Dominican. And on the right was my Los Angeles Hispanic population. And you can see by the green, which is the Amerindian component, that it's way more on the predominantly Mexican population than the Caribbean Islander population. And what's bigger in the Caribbean Islander population? African. So this all makes sense in the context of what we already know about this. And of course, the European component is varying. So you can distinguish where individuals are from, and yet we lump them all together in the current census. Now, we also wanted to look at the 185 del AG carriers and the exon 9 to 12 carriers, because our hypothesis, by the way, one of the things we did was haplotyping on the 9 to 12 mutation. And we found out that by doing dating work on that with David Goldgar, that it was about 72 generations old, which if you give an average generational time of about 20 years, that puts it at about 1,500 years old, long predating the colonial Hispanic influences and likely indicating that it was indigenous and came literally from Mexico. And this supports it. So we found that there was a statistically significant difference in the proportion of European ancestry versus the yellow here, which is the Amerindian ancestry. So again, finding empirical evidence that this was a founder mutation originating in Mexico. And, again, it became clear to me that, where's the next level of disparity? And part of the title of my talk today is about global disparity, and that's Latin America. So despite the fact that we've had commercial access to BRCA testing and way beyond since 1996, it's still not available to most of the world's developing populations, including in Latin America, to the at least to the public health sector, which is the largest sector in each of these settings. And again, I have so many wonderful friends here who are from various countries. So here's Dr. Virel Garza. She's in Monterrey now. These folks are also from Mexico. She's from up here from Colombia, so Medellin, Colombia. And we have others who are from, this is Dr. Abogadas, who's from Inen in Peru. We have a token man from Turkey here, Dr. Öztürk, which is a dear friend, and he came along for the ride for a lot of our conferences. But bottom line is that we had a very wonderful camaraderie with all of these individuals from all of these countries. And so we really wanted to see what we could do with regard to a roundtable. So what are the barriers to getting cancer risk counseling in the emerging areas of Latin America? So this is the participant demographics, but let's get to the outcomes. So barriers to care, no surprise, not covered for cancer patients by most health insurances, nor for their family members. Lack of insurance coverage for high patient out-of-pocket costs. Long turnaround time for genetic test results when they did happen. A lot of them were being done by homebrew. Absence of readily available provider training or expertise. Lack of institutional infrastructure. These all sound similar. It's implementation problems, infrastructure, and policy as well. Medical system was built to treat disease, not prevent it. That sounds an awful lot like our Medicare system. And lack of evidence-based guidelines specific to countries. So we don't have the space, we don't have sufficient genetic counselors, doctors, nurses, infrastructure. Barrier we have is cost, no surprise. But there's some other things that I thought were insights that were worth discussing. So they all, well, let's talk about solutions. So we need to collect evidence to support the efficacy of GCRA in their setting as an essential step. Further, they said that we would start with the data of the country, because once you have that, they can no longer say in the country, meaning your ministers of health and the like, that genetics doesn't apply to your country, that you don't have a significant burden of hereditary cancer, because if they don't collect the data, they can pretend the problem doesn't exist. But in fact, that's what's important, is to document this. This is actually Marcia Cruz Correa who gave that quote, and she was just the president and the chair of the last AACR meeting. So she's just an amazing person, a dear friend. If you have a well-mounted structure and you have everything organized, you have data registered, then you can project them at the institution, scientific level, political level, and population level. So that's where we came from, and we realized we really need to help implement there. So what are the tools we can use? What do we need? Well, we need to have people who are trained. We need to have coverage ultimately. So as you get up the pyramid, you need resources to sustain things. But down here, we need to at least get acceptance. and the need for a multi-level approach and the creation of a registry database. So taking that now into implementation science. So we need a registry. Well, I had a registry. So 47 oncogenetic practices across the US and Latin America. You can see their distribution here in Monterrey, Guadalajara, Mexico City, 2 sites in Colombia, so Medellin and Bogota, and then Lima, Peru. We have others out there. We also had Puerto Rico, but multi-generational pedigree data was being collected. Overall, the registry, when I left City of Hope, was at 30,000 participants with almost 5,000 from Latin America alone, and really able to generate a global cancer genomics translational research enterprise. I'm particularly proud of our visits there. So again, a lot of these people may look similar. So again, a bigger group, all involved from these various countries. But when we went to visit in Peru, which is the panel on the right, I'm particularly proud that in Spanish, on a huge billboard, is prevention. Love it. So that's why I took this picture and I got everybody to line up, because it's about prevention. And so they actually have a national cancer health plan in Peru, and it's still a lot of disparities in access, but at least they had the right framework, like right frame of reference. So what did we do with this? We went, we established, and we started seeing patients with them. But one of the first things we did was they had some archive cases, 100 breast cancers, 100 ovarian cancers, unselected for family history, but young at onset. This is the crew. Cynthia's always on the phone. She's a busy clinician. So almost every picture I have of her, she's on the phone. But, and I wanna highlight a dear friend here. Sandra Baladares was working for Life Sciences at the time, helped me get an ion torrent to put on my benchtop to do cheap sequencing. So I haven't been so innovative in finding genes, but definitely innovative in trying to find a cheap way to find the gene variants. So we were able to get BRCA testing to under $100 using the ion torrent. But on this particular trip, I'm highlighting people who are all, let me name co-authors here on this study. And let me show you something from that study, which we published in 2014. So shows you the disparity. Here's breast cancer, 96 cases. Look how many are stage 3 or stage 4. So late diagnosis. This is not necessary. If even all you had was mammography and doctor's breast exam, you would be able to shift this to stage 2, stage 1. But obviously a big burden in the population. They're young, so you look at the age range. And then the ovarian cancer is no surprise. This is the same as anywhere in the world, most stage 3 and stage 4. But we find that BRCA mutations are prevalent. And this may be a partial explanation for the excess of triple negative breast cancer that has been observed in Mexico. So when you think of Hispanics overall, the overall risk is not as high as the European population, but the proportion that are triple negative is higher and the age at onset is younger. I would posit that that's a genetic influence. And here's that mutation that I talked about. That's a founder mutation. And look at it. It was for the ovarian cancers. It was 35% of the positives were that one variant. That is a public health problem. And the same for the breast cancer, is a large proportion. Then again, here's our other founders that I mentioned before, right? So here's that intervening sequence variant. Here's the Spanish variant. Here's the Spanish variant. Here's the African variant. So our work discovering these things in the US is now mirrored in Mexico. We followed that up with another study of a cohort of 190 triple negative breast cancer cases. This I worked with Stephen Nerad on and Cynthia Villarreal Garza. And we used something I called the HIS panel. HIS panel was basically a sequenome assay together with that large genomic rearrangement assay that was used, and for $20, I could screen out 75% of the true positives. And that was what we used. So the only thing we used in this, we presumably missed a few mutations because they weren't on our sequenome, but for $20, for $5,000 in 2 weeks, we screened 190 families for BRCA. And look at the yield, 23% of all the triple negatives had a mutation. And look at the proportion that had that large genomic rearrangement. This is a public health problem. So again, look at here the number of the African-American mutation, 5 of them in that population. So pretty impressive. I'm going to come back to this cohort later because we've now used it for another study because they had clinical outcomes. So remember this cohort, remember this breakdown. All right, next piece. So we've got a cheap way to do the testing. We've got a registry. How do we train them? And so I was honored to begin the intensive course in cancer risk counseling. We called it an intensive course just to distinguish from all the other courses that were weekend courses out there. It's over 100 credit hours. We have track 1 and track 2. Track 1 simply had face-to-face workshops on the City Folk campus. And it was caseworking, caseworking, caseworking. The key to all of this is situated learning, so learning around what you have in your own clinic, and a long-term support network, which we called the Clinical Cancer Genomics Community of Practice. Kathy Blazer, who was my partner in crime on all of this, she was the first genetic counselor that I recruited. She worked together with me for 24 years. Kathy ultimately got her doctorate in education on top of her genetic counseling degree and now leads this program, and she's featured here. We've obviously published a number of papers on the outcomes, and when you do these little, I forget what they're called, these little signpost things to see how many. So 104 people trained in California, no surprise, biggest state, 45 in Texas, and you don't see the number, but about 45 or 50 in New York, where they should be, where the populations are. But look at how many we've trained in other countries. So we've trained a good number in Mexico, Costa Rica, Colombia, Peru, and Brazil. So we're very proud that we've covered a lot of countries as well. And that gave us our educational tools. So we can train them how to do it. We have the registry, we have the testing capability. We're 3/4 of the way to implementation. So I coined the name, and as you know, the acronym can be everything, but I love the name as it turned out. Genomic Risk Assessment for Cancer Implementation and Sustainment, Gracias. And although genetic risk, again, here's the premise. Although risk assessment is a standard of care in developed nations, it remains limited in Mexico. You could swap in Africa, you could swap in a lot of other countries into this statement. Roundtables identified limitations, which we covered, and we described the first project to use implementation science methods to develop and deliver a multi-component implementation intervention that included the comprehensive training and practice support. We had a web-based progeny system, so they're building pedigrees, and it goes straight into our database. So it was a great opportunity for us to both support their practice and create the easiest possible way for them to give us the data back for the data analyses. Low-cost testing, academic detailing, and GCRA registry protocol to enable both testing and outcome measures. This is the framework. And I'll highlight here that, first you have to find champions. And I met Cynthia Garza at I think at San Antonio Breast Cancer Symposium meeting. At the time, she was doing a breast fellowship with Stephen Nerod's group up in Toronto. And when she went back to Mexico, we started some collaborations. And again, introductions, but you need champions. So we had champions at different sites, and I'll introduce you to others as I go along. We held on-site meetings with key leadership and with staff and key leadership. I did academic detailing, so I would do a grand round. So we would do things to raise the awareness of genetics as a standard of care opportunity, and also to highlight for the leadership at a given place just how cool the people they had working for them were, and that they really need to be supported. We did web-based follow-up meetings. Then we would get proficiency training through the course, membership in the registry protocol. Sometimes it took a year to get through the IRB. They would be involved in this, and then we would apply the tools. So we're building capacity, right? So that's one of the concepts: engagement, readiness, planning. These are the D&I concepts: capacity building and resources, and then implementation support, monitoring, and quality assurance. Because we're surveying all of this, we had a lot of other, I didn't put a table of all the surveys, but suffice it to say we had a number of instruments to measure our impact on each of these elements, and then program implementation assessments. And then at the end, you get at the effectiveness, the quality maintenance, and so what are the re-aim endpoints: reach, effectiveness, adoption, implementation, and maintenance. And then repeat as necessary. You basically cycle back. And eventually you keep adapting, and you need more champions if you're going to expand. So academic detailing. So again, going to these various sites. This is a visit we made to Tech Salud in Monterrey. This is their geneticist who trained with the course. There is Cynthia, there's Kathy, and our team here. This is also one of our research associates, bilingual, bicultural, CRA. And then this is in Mexico City. Why are we here? This is a doorway to the clinic. So Kathy, who is bilingual, would actually proctor the evaluations so that we could say that not only did we teach them how to do cancer risk counseling, but they were implementing it with the best fidelity in their clinics. And so we would see how they were dealing with results. And the other thing about doing all of this sort of detailing and trying to raise awareness was sometimes a savvy hospital would bring in some press. And so here's Cynthia and me in one of the local newspapers. And this was a wonderful cover story about the collaborative effort and again, brought in more awareness. They had a whole flood of patients coming in after this awareness. So what are some of the outcomes that we published recently in JCO Global Oncology? So for each of these sites on the left, you can see this. This is also an analysis of our evolution of cheap testing technologies. So we tested everybody with a 3' assay because that was easy, $1, 96 cents or 86 cents rather. Then we did the HIS panel for a while, but then we went into full sequencing and CMV analysis via MLPA. And then you can look at the yield. So in some countries, the HIS panel stood the test of time, at least 59% here. PV frequency overall, this is combining all the methods, really was pretty substantial, 9% at the lowest to 26% at the highest. And by the way, this reflects largely the selection criteria for the respective population. How do I know this? Because we looked at the family histories. And I believe this is the first documentation or the first validation of, for example, BRCA Pro as a predictor in a Latin American population. And this is Jessica Clegg, who was a doctoral scientist in my group at the time. And this was showing the area under the curve, 0.76. That's totally respectable. So that BRCA Pro looked to be a good way to estimate the burden in these families. And it also helped us to know that, yeah, we're probably finding what we expect to find because the curves are so predictive. And then we moved on to multiplex amplicon, so the carriers panel that I did with Fergus Couch. So we went on to all of the various genes that you would use in multi-gene panel testing. So we're moving them along gradually, and we were able to do this latter test for about $70, $80 out the door with clinical grade sequencing, but not CLIA. Now, other outcomes. So if you look here, this is University of Guadalajara, in National Cancer Institute, Mexico City, Tech Salud, Monterrey, Nutrition Institute, Mexico City, one of the most important institutes in their country. Remember, targeted reach. So we simply said, how many patients did you have who were under 50 with breast cancer? How many triple negative patients did you have in a year with breast cancer? Since we couldn't do a chart review to identify each one and whether they were referred, we could look at how many got registered and referred and made these estimates of reach. So this is a measure of reach of the targeted population who were referred and subsequently tested. We had almost nobody who didn't get tested once they were referred. They were very much engaged in the process. And we used somewhat modified at that time NCCN eligibility, because I said anybody with triple negative, certainly vindicated now by the NCCN change in guidelines to all triple negative. But we did all triple negative there because we knew about the founder effect and what we were seeing, and we knew that we needed to cover all of them. But you can see the various yields. And again, there were more, for example, in the population here at the University of Guadalajara, they had more unaffected people with family history as compared to INCAN, which was almost exclusively affected individuals. So again, the proportion totally reflective of what you'd expect. We also then tracked their accruals, rocketed up, and then came back down here. What happened at Guadalajara? Their sole provider was out of maternity leave twice, actually. And how did we respond? Later, they came back up because we trained more people at their site. So they had some depth, helped them with depth. This is the INCAN, and they took off on their own from there and continued to do this. And then this was Tech Salud, and this is the latest edition was at Nutrition. So again, you can see that we're able to see these trajectories. Now these others over 2 years are continuing to go up, and they've continued to be really active. So GRACIAS resulted in increased reach and sustainment of GCRA services at 4 major centers in Mexico. The yield of BRCA pathogenic variants was comparable with the yield from US high-risk screening clinics. GCRA risk stratification could inform allocation of limited resources and help result in the prevention of cancer. So this isn't a luxury test. This is a way to stratify risk and take limited resources and apply them most effectively. Implementation science developed for this project may help scale up dissemination in other settings, including reverse engineering of our learning there into rural communities and safety net hospitals in the US. Now, just a little bit more granularity for the Tech Salud site, just to show you what is an evolving practice looks like. So here we are, 2016 start, 71 patients tested. Already by the next year, 7 relatives tested, so cascade testing, some people getting risk reduction surgery. And you come all the way out here, look at the proportions. We're now seeing substantial relatives, I would argue better than most places in the US, and they're getting preventive surgeries despite the lack of coverage for that care. At-risk family members, 44% of at-risk family members were starting to get tested. Affected probands, again, 14.8% had a mutation. And again, among the family members that are tested, right there, Mendel's law 50-50, right there. Now, how do they get risk reduction surgery? And this is where, a lot of people argued, and I got grant reviewers who said, why are you going to tell them risk information if you're not going to guarantee somehow that they're going to get risk reduction care? And that was like to insist that people be ignorant and not be able to advocate for themselves. I have a serious problem with, but basically here's what my colleagues did. And I knew they would do this because that's what people do when they're on a mission. They figured out how to get it covered. So mastectomy is not covered as a preventive, but they could consider it in a single procedure for mutation carriers with prioritization for testing. And they would do a salpingo-oophorectomy and label as adjuvant therapy for that ER-positive breast cancer, even though their true purpose, rather than using tamoxifen, was to get them ovarian cancer prevention. They also generated non-governmental support. So in fact, this foundation was started by one of the clinicians and also with the hospital kicking in as well. So really they became innovative themselves in figuring out how to get this done. Now we started to look at, well, what about the uptake? And this is a couple people. This is Kai Yang, who is my biostatistician and database guru at the time. And this is Dr. Chavarie. Now, Yanin Chavarie is just like Cynthia. These are some of the most bright medical oncologists you will ever meet, and they are shining stars in Mexico. But she and I have been doing a lot of work together. We published a lot of papers together now, but we're now looking in the midst of a uptake of risk reduction surgery study. Because now that we have the registry and we had all this uptake, now we can start saying with a median follow-up of 2.6 years, we have carriers and non-carriers, and we can look at the uptake. So among the BRCA carriers, who they got risk control out of risk reduction mastectomies and risk reduction salpingo-oophorectomies. Now, a number of the non-BRCA carriers got risk reduction mastectomy, but part of that's pragmatic. If you're a young woman in Mexico at 40 years old who's got unilateral breast cancer, even if you didn't have genetic test results, the likelihood you're going to get MRI or good screening afterward was significantly diminished. So many of them chose bilateral mastectomy. So I'm not surprised about this. And I'd argue that in the US, just based on young onset, many get that done empirically. But look at the uptake of the RSO. So we're not getting that done in those who aren't carriers, totally risk appropriate care. We're also able to subdivide a little bit of what are the predictors. So some of the behavioral science that goes with this. And sure enough, US versus Latin America, there's a gradient. More likely to get access to care, not surprised. Previous pregnancies, significant. Why? Because if you had previous pregnancies, you were more likely to have your family done. Family history cancer was a driver, no surprise. Age, younger, more likely, but not significant. Marital status, not significant. Previous mastectomy, not significant. Now, for the BRCA negatives, you see a similar thing. Again, look at how many, this reflects what I just told you about the US, many more empirical mastectomies done in the US than in Mexico. So I will say that we probably need to get closer to risk appropriate care in the US. And so you can see the other status factors. So, and again, breaking it down, looking at the gradients. So for risk reduction mastectomies, overall, 39% had it done. This is for BRCA carriers, 53% in the US, 29% Latin America. Again, 67% for salpingo-oophorectomy in the US, 21% for Latin America. People would say, well, that's not enough. And I'd say, wow, I'm glad we saw any at all. And so it's promising that we'll get there. And I would say recent paper in JAMA on the uptake of salpingo-oophorectomy in individuals in the US is still suboptimal in this context. So risk GCRA in well-trained individuals with appropriate practice support influences risk-appropriate uptake, especially for BRCA carriers. The rate of risk reduction mastectomy and oophorectomy among Hispanic women is lower than that reported in previous studies of other populations, and it's significantly associated with residents. And this may also be a reflection of disparities in access, as well as health literacy and some cultural barriers regarding the impact on these families and individuals. All right, so now segueing from that implementation study was now to get at what implementations got us opportunity to do, which is epidemiology in Latin America of BRCA. We published this in the Nature Partner Journal Breast Cancer last year. And again, this is on 1,627 patients, all of whom got full BRCA sequencing in one form or another. So we peeled off right off the top 23 cases for basically $23. And that's because that founder mutation. Didn't have to do more once we found that. Then we did the sequenome, which was about $20, picked up a bunch of positives. They were confirmed in other ways. Then we had moved evolutionarily into full sequencing on the ion torrent. Again, picked up some positives that weren't on the panel. And then for those that were BRCA, we did BRCA1 MLP because of the frequency of CNVs, and we found additional BRCA1 large genomic rearrangements. So the end result, 1391 patients were negative, 236 were positive. Now, when you look at the distribution, this is a table of those that were at least 3 or more observations. And you'll see that this is our large genomic rearrangement up here in these very confusing HGVS terminology for large genomic rearrangements. I defy anybody to really define those well. But we had 23 of them, and they're almost exclusively from Mexico. Originally, we found one in Venezuela, but it was in a Mexican person. This is the Jewish mutation. So I told you about the Ashkenazi, the Jewish founder. And then the other ones that I've mentioned to you. But the other thing to note is that you see where it says NC, that's not seen in ClinVar. And so here's a number of important recurrent pathogenic variants in the Mexican population, and they aren't in ClinVar. That's a disparity. Oh, so the top line is indigenous influence, the next is the Jewish diaspora, and the next one's the colonial Spanish influence. So I think it's interesting to mix history, anthropology, and dissemination implementation research. Now, what else is important about proper ethnic controls and having the right populations? This is my dear friend Susan Newhausen. I was able to give to her almost 1,000 BRCA negative Hispanics with breast cancer for work she and Elad Ziv did doing whole exome studies. Well, this was the first study out of that, which I led, which was about the multi-gene panel genes. And what we found in that, which was interesting, is first we knew that some of these PALB2s, which are truncating, their frame shifts, were recurrent, and showed that they, in fact, had a significant risk associated with them by using exact controls, but also using the multi-ethnic cohort and City of Hope controls. So proper ethnic matched controls essential. Second, this missense variant in CHEK2 was being called a variant of uncertain significance when it was discovered in the US. We showed convincingly with the appropriate controls that it had a risk, and I would argue this risk is every bit as high as the 1100 del C. And again, and here's a 4.1 using, again, contemporary controls. And I would say that, this helped to reclassify that. And so it is now, it is almost always classified as at least a likely pathogenic variant now in ClinVar because of our contribution. But again, the importance of ethnic matching. So moving to a little bit to genome-wide association and thinking about polygenic risk scores, equity is an issue. We need to have insights from multi-ethnic populations, and I'm glad the Confluence Project from the NCI is going to address that in large part by really enriching for a lot of individuals. I'm part of Lagino, which is the group that Laura Ferriman is leading, but I want to highlight this study that Laura and Elad had published, which showed that there's actually a protective SNP on 6q25. And if you fail to put that into a polygenic risk score, you may be overestimating in a Latin American population, for example. And so it has been put into some of these now. We also published, I was on this paper with them, which looked at a Latino population using Elad and Laura's SNPs that they had used for their genotyping. It was 71 SNPs. And what they showed is that it actually was pretty predictive, even though it was mostly based on the European ancestry. So we still don't have a truly ancestrally tuned PRS in this setting, at least, but it points out the importance of that ethnic matching. Now, the last component I'm going to talk about is really precision medicine, and that is targeted therapy due to synthetic lethality associated with BRCA1 mutations. One version of resistance that is acquired, and this is a case that had 185 del-EG germline. And if you look, this paper, Elizabeth Swisher and others had published, this is immunohistochemistry showing that they had no expression of BRCA after treatment, expression of BRCA. What the heck happened? Well, they had a reversion mutation. And that reversion mutation put it back into frame and gave partial expression of BRCA1, enough to cause resistance, and yet probably not enough to be perfectly normal, and long after the cow had left the barn. Now, we've gotten more sophisticated about this. So this is using ctDNA to observe the same thing. And so you'll see here, this is the presence or absence of reversions in ctDNA associated, and there's all the resistant ones right here with the reversion mutations. And here's those that were sensitive to rucaparib. And one would argue that mostly analogous is going to be platinum sensitivity. Now, these are the reversion mutations that were observed in that previous study, again, showing multiple ways when you start out with a wild type sequence and the primary mutation, how many different types of reversions you can have. This is just like a lottery. It's just continually churning out these because of the genomic instability. But what's interesting is now think about this as a concept. So thinking about reversion mutations, I hypothesized nearly 10 years ago that if you have a large genomic rearrangement where a good portion of the gene is missing, there's nothing there to rearrange and put back into frame. Therefore, it wouldn't be as strong of a mechanism of resistance. And I've been searching for years for the right population to do that study. Now, we go back to my study of 190 triple negative breast cancers from Mexico. And again, this is just highlighting that it's not all reversion mutations. There are some loss of PARP1. There's also pharmacologic resistance by P-glycoprotein pumps. And this is sort of a good schema. This is a great review paper by Lord and Ashworth in 2017. But nonetheless, the reversion mutations are relevant. So here's a study we just published in Cancer Research Communications. What was this? The 190 patients we saw in the triple negative study previously, Cynthia had been following them now for 10 years of follow-up with clinical study grade follow-up. They had some heterogeneity of the chemotherapy regimens, but these were all triple negative patients. We already knew their genotypes. Here are the indels, the insertions and deletions. Many times it's, one base pair change caused a truncation versus the 9 to 12 deletion, which represented 17. So there are no studies out there that had that high representation of a large genomic rearrangement that allowed us to test the hypothesis about survival. And what did we find? Fascinating, because when we sampled them DNA-wise, I'm sure some people had already died, but everybody who are carriers and non-carriers, indels versus CNVs, going forward from the point of sampling, and again, we published that paper in 2014, 2015, so 5 to 10 years of follow-up. Look at this, overall survival at 5 years. If you had all PV, CNV, and other, we had 100% survival of the CNV carriers. That's just remarkable for anybody with locally advanced disease at the least. And you can see recurrence-free survival and overall survival were very high and were higher in the CNV carriers versus other BRCA PVs versus non-carriers. And this is shown graphically here. So this is years from breast cancer diagnosis, probability of overall survival, and this is carriers versus non-carriers. The curves separate, but it's not significant. And that's really a numbers game, how many people we had. Here's, however, overall survival. These are the large genomic variant carriers. These are the indel carriers. And look at that. We just made significance. I know one or two people, one direction or the other, might have removed significance, but to me, this is a proof of principle and at least supports the hypothesis. What we are missing from this study, and I wish we had the pathology data, would be to go back and look for the reversion mutations in the indel cases, because that would have taken this from a Cancer Research Communications article maybe to Nature Genetics. You never know. Nonetheless, you can see here, this is recurrence-free survival, not as much of a split, but still a trend toward better health for those who had the large genomic rearrangement. So, in summary, hereditary breast and ovarian cancer affects all world populations. Common ancestry, geography, world history, it's cool. It's fun to do this and really connect things to history and anthropology. Again, this large genomic rearrangement, I think, is a significant, important problem. We estimate it really occurred a long time ago, and Amerindian context is suggested by our ancestry informative markers, as well as historical concepts going on at the time in central Mexico. Prevalence of 185 DLG really reflects Spanish Jewish history and the legacy of religious intolerance. Representative populations are needed for variant curation and genetic estimation. Training is essential. Our advances in next-gen sequencing and ever cheaper sequencing really have to be brought to bear to enhance access globally, and I've demonstrated that it can enhance access with great economy. Differences in post-GCR uptake of risk reduction surgery may be a reflection of disparities in access between countries, as well as health literacy and cultural barriers, and international collaboration is essential and can influence care locally here as well. And as I like to say, at least during the last administration, we like to build bridges rather than walls. So these are some of my wonderful dear colleagues. One of the last clinics we opened was in Chiapas, in Tuxtla Gutierrez, which is one of the most poorest areas in Mexico. Francisco Gutierrez, who's the CEO of the Latin American School of Oncology, and his colleague, this was a community event we did with, these are all clinicians in the community, nurses, doctors, educational detailing. So again, academic detailing, following the same Gracias Project rubric. This is at nutrition. And this was a follow-up we did in Mexico City with a roundtable. And all of these are clinicians who have taken our course and have tried to implement or are planning to implement risk assessment in their clinic as part of the Gracias Project. And I'll point out, here's Francisco again. You see Cynthia in here, there's Yanin. This is Bita Nehere, one of my genetic counselors when I was at City of Hope, just a wonderful individual, very committed. Joseph Herzog, who worked in my lab for 24 years and did a lot of the sequencing. And then also back here, this is a doctor who is he was the head of INCAN, and then was also advising their national cancer plan. And so genetic risk assessment is now at least on the table to be included in their national cancer plan. So, you know, not shy about thinking we might be able to influence even a country's risk assessment. I need to, of course, acknowledge all the funders that made this just amazingly possible, and in particular, the Breast Cancer Research Foundation, who funded me for the 7 years before I transitioned into industry, and really supported this so much. And I want to thank all my friends and colleagues. And again, this is a legacy of love, really. So thank you very much for your attention.
Well, thank you, Jeff. I'm I'm left in awe. It's really, really, really amazing work. Georgia, do you want to? Are you there?
Hey, Georgia.
Sorry, I know we've been half a country away, and now you're close by, but we're still doing things by Zoom. So thank you so much
that's okay.
for coming.
Well, I'm kind of excited about visiting the center, actually. You know, I was looking forward to that, but that's okay. I'm glad we're getting together tomorrow night.
Right. So you've done such a broad stroke of, all of the issues going along, and at almost every one I kind of had some questions and just some thoughts.
Yeah.
So if we have time, so people can, interject, but one of the things that I would like to learn a little bit more about, just from a clinical standpoint, because we have some people here who are Mexican origin, who we find mutations, and we kind of get a full stop. We don't know what to do with those people. And I'm going, well, these 4 wonderful centers you're working with in Mexico, is there a way that other institutions can just make a clinical sort of referral?
Absolutely. So where that happens, Georgia, all the time, because again, in our clinical cancer genomics community of practice, the beauty of that community of practice is we have an asynchronous listserv as well. And there's always somebody who says, I have a family in Michigan whose family, this is also part of it, is when I'm taking care of my patients in Los Angeles, their family.
Exactly. That's what I'm thinking.
Totally
we need
connected.
Cascade testing that could be done, and how do we reach them?
Yan and Chavarri in Mexico City, and they find a way. We get all these people. We have Mexico City, Guadalajara, Tuxtla Gutierrez, and Monterrey, all represented just in this network alone. They're all part of the community of practice. And so we're trying to, Kathy is trying, Bill at Blazer, we're trying to create a registry where people can find contacts, where to get risk assessment across the country, across the world. Right now, it's still internally facing to the community of practice, but there's almost always somebody who is in our community of practice in many places in the country where they can have access and say, yeah, we've got a patient who's at. So, and the others that I'll be happy to forward those type of emails for your patients.
That was just my next question, is sometimes it's a little difficult. And then my other question, I just would love to hear your thoughts about it. As I was looking at your organization and the things that you built, across the multiple countries, it seemed like it was a little similar to the H3 Africa. I'm going to use consortium. I don't know if that's the right word, but it seems like the work that is there that you've done would certainly elevate it to a program like that could be a little bit more, I'm going to say longer acting. And then generate some interest, from our own NIH, because they're active partners in H3 Africa.
Yeah.
Because I think that's the way to really build those bridges, and I really like the way you said that, because is really think about how many areas can we focus on this, because you've talked about clinical care. You've talked about epidemiology. You've talked about clinical utility. You've talked about
science,
what is the right test and how do you develop it, like all of that. And I was just envisioning. So anyway, I just want to kind of think your thoughts, and is there following in their footsteps a little bit? Would that be a way to help? Particularly,
I'm just going to dovetail, Georgia, because you went through everything Dr. Weitzel talked about, including therapeutics. So there's a question in the chat that I wanted to get to. So from Melissa Parker, am I understanding reversion correctly, that it is a mutation that corrects or partially corrects a different mutation? I think what you were getting at is it corrects itself, so the PARP inhibitor is no longer working. Is that? But
That's
you can
correct.
explain it.
Because again, this is you guys above all can teach these folks about basic genetics, right? So your triplet codon, anything that's that's anything other than 3 base pairs is an insertion or deletion that causes a frame shift. And so all you have to do, and the classic examples that have been sequenced and demonstrated are, you got 185 del AG. So you're going along, you're in exon 2, I believe, and it takes 2 base pairs away, causes a frame shift. I used to know how many amino acids later, call it 15, I don't remember. But if you simply go maybe 10 more base pairs down and take 1 more base pair away, it's suddenly back in frame because it's a number 3. Or you put 2 back, it's back in frame. And so while it might skip a small modular component of that protein, you are basically allowing re-expression. They've demonstrated re-expression of RNA, re-expression of protein. And many times they're still hampered. They're not perfect proteins, but they're enough to cause resistance, unfortunately. But they do revert, and it goes way back to classic genetics and some of these beta-galactosidase assays we used to do in the lab. This is just cool. To me, I love the concept of reversion mutations just as a conceptual framework, and there's lots now of demonstrations of these reversion mutations. And by the way, they aren't necessarily induced by therapy. They're selected for by therapy, because prior to therapy, these patients have a lot of DNA instability. That's the whole point of BRCA. They've inherited mutation in the germline. They've had a somatic hit that then creates that, recessive at the cellular level concept, and they've been scrambled for a period of time. And that's why they talk about HRD, and as Andrew Tutt would say, the genomic scar. So you can still see the genomic scar still looks like HRD, but they're no longer sensitive, and part of it is because what's grown out is what was left when you got the sensitive cells killed by platinum or PARP inhibitors. So anyway, you've got the concept right. It's exactly that. You're putting it back in frame with varying degrees of success of a functional protein.